Well, welcome everybody to the 2015 Marsden Lecture. My name is Stephen Paris. For those of you that don't know me, I'm the medical director, I have the privilege of being the medical director of the Royal Free London NHS Foundation Trust, and it's my pleasure tonight to welcome you all to this annual event. Of course, it gives me great pleasure to welcome our guest speaker for the night, the 2015 Marsden Lecturer, Dame Sally Davies, the Chief Medical Officer, and I'll be saying a few words about Sally in a moment before she commences her lecture. A few other special mentions as well, so a particular mention to our friends from the Cordwainers. I'll say a few words about the Cordwainers again in a minute, but we're particularly pleased to have the clerk, John Miller, who's an old friend of the organisation, and this year's master, Jon Rubinstein, who will be saying a few words as well later on. And then also welcome to our medical student prize winners, who I hope are here, because we'll be giving the medical student best prize awards later after the lecture has finished. So I probably don't need to remind you, but for those of you that haven't been here before, I will tell you for the first time that the Marsden Lecture is held each year, third Thursday in November, so you can put it in your diaries for next year. And it's held to commemorate the founding of the Royal Free. And the Royal Free was founded in 1828 by William Marsden, and there's a photograph of William Marsden there in the corner of Sally's title slide. And one thing that you will notice that's different from last year is that we have in the last few months opened our history wall outside. So if you go outside, immediately opposite there is a wall which outlines some of the notable historical events around the Royal Free. So you can learn all about the founding of the hospital in 1828. It was at the time, of course, called the London General Institution for the Gratuitous Cure of Malignant Diseases, which is a much snappier title. And the board, or the governors who changed that name, not sure why they did it, but anyhow, in 1833 it became the London Free Hospital, and then the Free Hospital a few years later, and has remained the Free Hospital in one form or another ever since. And I'm sure you all know the story that Marsden found a destitute woman on the steps of a church in central London who had been refused treatment by a number of notable hospitals. He took her in, she died, and he was so appalled that she couldn't get care that with some friends and with the subsequent help of the Cordwainers funded the establishment of the Free Hospital. So it is called the Free Hospital because it was the Free Hospital. And as we often say, it predates the concept of the NHS by a good 120 years. Many notable events in its history outlined on the wall. So you will know a long history of treating infectious diseases. So it got its royal moniker in the 1800s for treating patients with cholera at a time when all other hospitals in London refused to treat patients. And as you know, to this day, we still treat infectious diseases patients where it is difficult to treat them elsewhere. So that lives on. A great history in terms of women in medicine, so the first medical school in London to take women, and many notable women have graduated from here, including have worked here or graduated from here, including Dame Sheila Sherlock, who was Professor of Medicine here, founded liver medicine, and so it's a particular pleasure to have leading women in medicine in the UK lecturing tonight. Now, for those that are really interested in the history, Neil McIntyre, who's sitting in front of me, who was Professor of Medicine here, has written a book on the history of the Royal Free, and it's a very, very good read and a very comprehensive history of the organisation. And it's entitled How British Women Became Doctors, so it absolutely alludes to the history of women in medicine that I've just mentioned. So these are available direct from Neil, and they are available to purchase from the library, the medical school and the hospital library, and all profits on this are going to the library in a charitable donation. So a good Christmas present. It's only a few weeks, and it is available in paperback as well as hardback, but hardback's better. So there you are. Right, okay, so let's move on to the main event. So it's a great pleasure to have Sally here tonight. So, as I'm sure you all know, Dame Sally is the Chief Medical Officer for England and also advises the UK government. And she holds responsibility for research and development and is the Chief Scientific Advisor for the Department of Health. So you will know that the CMO is the independent advisor to the UK government on all medical matters with particular responsibilities regarding public health. She's also a member of the World Health Organization Executive Board and the International Advisory Committee for A-STARS Singapore, and she's advised on many other countries on research strategy and evaluation, including Australia and Canada, and also advised governments in Norway, New Zealand, Japan, Hong Kong and the Caribbean. As Chief Medical Officer, Sally publishes an independent annual report, and her first, in 2013, focused on infections and highlighted the national global risks of antimicrobial resistance. And since she's become a tireless advocate for action to address antimicrobial resistance, including the World Health Organization resolutions, and she's chaired their strategic and technical advisory group and written a book called The Drugs Don't Work. She's even given a TED talk for those of you that are into TED of the same name. And it's actually very fitting that she's talking today, because you will know that antimicrobial resistance is again in the news. And I was on the way to work this morning, but I'm told it was the first item on Radio 4's Today programme after 7 o'clock for those of you that listen. So it's very, very topical. And Susan, who's sitting there, I know has just given an interview to the BBC, who were in this afternoon. So very pertinent that you're here today. So Dame Sally was awarded Dame Commander of the British Embassy, British Empire, DBE, in the New Year Honours list on 2009 for services to medicine. And in September 2011, she was conferred Emeritus Professor at Imperial College London. And finally, she was elected a Fellow of the Royal Society on the 1st of May 2014. And I know she graduated with an honorary degree from Warwick in January, because she was in the same graduation ceremony that I was in, but I was sitting in the back getting a minor degree, whilst you were getting an honorary degree, so much better. So, Sally, it's a real pleasure to have you here tonight to give your talk, which is entitled Antimicrobial Resistance, the Global Problem.
Thank you very much. It's good to be here again. I was trying to remember when I last spoke in this hall, and I think it must be about 15 years ago. And then it was about research strategy, which I still care about passionately, as well as the fact that you are the medical school where women started, and that, to me, is very important. I gave a policy seminar to lots of politicians, among others. Have I got this right? I'm not sure I have. Maybe I'll do it this way. Earlier this week, and I said, remember that Ebola epidemic? And they all said yes. And I said, I bet you felt very worried and uncomfortable. And they did. And what I wanted them to think about was the number of deaths. You know about that, 11,300 and over 28,000 cases. You know that you looked after the 3 British patients that were ill here phenomenally. And I want to pay tribute, before I start to talk about anything else, to the whole hospital. For the infectious diseases unit to have done as well as you did, and such a wonderful job, didn't mean just leadership there. It meant the rest of the hospital also had to flex to support it. I know about the pharmacy, the communications, the engineers, the catering, everyone pulled together to make sure that you could care for those 3 patients optimally so they lived. In fact, of course, Pauline Kafferke, if she'd been elsewhere, probably wouldn't have done, and we wouldn't have learnt about the CNS late effects. You did a fabulous job. Thank you. And what that epidemic showed, and is still showing, nearly through, but not quite, is the devastating impact of infectious disease and what that can do. And then if you begin to look at antimicrobial resistance, you begin to realise that we have not moved past infectious diseases. It was in the 60s that the American Surgeon General said, we can close the book on infectious disease. No, we can't. And actually, we have bacteria that are a problem, but globally, look at TB. 3.5% of new and 20.5% of previously treated TB cases had multi-drug resistance in 2013, and it's only got worse. In Southeast Asia, 1 child every 5 minutes dies of infection caused by resistant bacteria. Are we going to move from the present 7% of deaths caused by infection back to that pre-antibiotic era of about 43%? There's no doubt, as AMR, antimicrobial resistance, goes up, we are at risk of that, unless we find ways through it. And we've already had far more deaths each year than the Ebola deaths. It's just that they're hidden deaths, and people haven't been worrying about them. Of course, Fleming himself was well aware, and in his I found it. I was just being silly. In his acceptance speech, he did recognise that antibiotic resistance would occur and it would cause deaths. So this isn't a new realisation, it was always there. Now, oops, gone the wrong way. Let's see if I can get it the right way. Now I'm going to win. I could talk about viruses. 7% of HIV viruses are resistant to the first-line therapy. We know that some flu viruses are resistant to oseltamivir. Fungi resistance is going up all the time. But generally, when I talk about AMR, I talk about the pressing issue of the moment, which is bacteria and antibiotic resistance. And you all know about the global golden age of antibiotics and how penicillin, sulfonamides and others happened, but we're beginning to run out of them. And what would that mean? To this audience, you all know what it means. Cancer treatment is underpinned by antibiotics. I have been explaining to a number of major pharma companies who say to me, yes, Sally, we'll stick to what makes us money. We'll stick to our areas and you can get someone else to make antibiotics. And I say, so when I get cancer and the doctor says to me, well, Sally, we can give you this treatment and it might cure you, but you are most likely to get an infection and we may not have an antibiotic to treat it. Will I choose my bucket list? I might. It depends on the unpleasantness and the likelihood of cure and everything. So chemotherapy, transplant, at any time, if you go to Southern Europe, there are bone marrow transplant units closed for deep cleaning. It happens in this country too, but much less often. As Susan can tell you, because she's expert in this area, if you look at the data, the further south you go in Europe, the worse it gets. We cover operations, caesarean sections, hip replacements, things like that, with antibiotics, because there are then far fewer infections, the outcomes are better. What happens to the 1 in 4 deliveries in this country who are caesarean sections if we don't have antibiotics that work? This will change it all. And in fact, antibiotics have added 20 years to our lifespan. And at the moment, in Europe, we have the equivalent deaths of a Boeing, I'll never remember which sort of Boeing, I think it's a 767, dropping out of the air every week. Now, if that was known about, people would begin to sit up. And it's a very complex area. This isn't just about humans and how we use antibiotics. It's about all sorts of areas. It's about fish farming. In many countries, antibiotics are just tipped into the fish feed, and animals, including fish and us, do not break down antibiotics. They go straight through us and out into the environment. So the sewage gets it. agriculture, spraying of crops, wildlife pick up antibiotics, pets do. I think we need to change it from companion animals. Food animals. Over 70% of antibiotics used in this country, worldwide, go into animals. And in many countries, led by the United States, they are used for growth promotion. It's cheaper to use antibiotics than good hygiene. I think it's terribly worrying. And then, of course, there's the food processing and a bit more complexity, just to entertain you. Meanwhile, quite a lot of battleships have tetracycline in their paint to prevent the barnacles growing. Antibiotics are cheap and they're used everywhere. So why am I worried? Well, I'll come back to it. We're not looking after the ones we have, but when a number of us in this room, who I know well, trained, we were living in a golden era of antibiotics when, if the microbiologist said to me, Sally, your patient has a resistant bacteria, I just said, oh, open the cabinet and tell me which one I'm using now. But unfortunately, in clinical use, we've hardly got anything that was not discovered by 1987. We've had a real void. We're beginning to get stories, Taxpaxin, things like that, of potential antibiotics, but they're not yet through all the clinical trials, and they're very limited in use. They're quite limited spectrum, whereas we've had very broad spectrum, which has made it very easy for empiric treatment. Now we have a bit of a problem, because as I go around the world, if I say from Britain, don't use antibiotics because you get resistance, we've got to save antibiotics, what the developing world here is, so it's all right for you to use them, but not for us. There's an access issue. More people die of lack of access to antibiotics than die from resistance at this moment. But use is going on all around the world, particularly in the BRICS, Brazil, Russia, India, China and South Africa. You can see Brazil there with, over the decade 2000 to 2010, a 68% rise in use, 37% in China. This is development. We expect an increase in the use of antibiotics. But how do we make sure that the increase of use is actually carefully balanced with appropriate use and conservation? And that's one of the big questions. And of course there's great variability, and Susan leads the big studies in this country which show the variability across the country, and the Americans have similar variability that cannot be explained by case mix. But access versus excess, the fact that development leads to an increased use. So, we clearly need to do something about it, and the Prime Minister was good enough to commission Jim O'Neill, who's an economist who used to run Goldman Sachs Asset Management, to do an independent review of the issue. I was very keen to have an economist. I don't know how many of you remember the Stern review of climate change and how having an economist woke the whole world up. And what Jim's modelling has shown is if we don't do anything now and we look at 3 of the 7 key infections and drug combinations that the WHO are worrying about, we will have 10 million deaths a year. And look how that, in purple, compares with the present deaths of cancer. It will become a massive problem. And the economic impact is that you would lose the equivalent of the UK GDP to the global gross domestic product every year. And cumulatively, it would cost us about $100 trillion by 2050. So this is really important. And it's not something we can close our borders to. We had great debates about border closures because during Ebola, as Mike will remember, but, first of all, we couldn't for that. And for this, we can't. We are truly global. And what I've shown you here is 2 drug-resistant bugs, one starting in North Carolina, the other starting in Delhi, and how within just a few years they were all over the world. And they're both rather nasty ones. One of the reasons there's been so much news about antibiotic resistance this week is it is the World Antimicrobial Resistance Week. It's the first time we've had a week. That's the result of the work we've been doing with the World Health Organization, which I'll talk about in a minute. We've for a long time had the 18th of November as European Antibiotic Awareness Day. But yesterday, The Lancet published a paper which shows that in a particularly nasty antibiotic that none of us would really want using in us, but is used as last resort, there is now in China, in the pig farming, resistance that goes not only vertically, that is to the children and the grandchildren and the great-grandchildren, but horizontally, hopping from one bug to another bug that's sat next to it. That is terribly worrying. Led by people from the UK, and this polymyxin resistance, I think, is terribly worrying, and it's been picked up everywhere and talked about. And so it should be, because we need to think about this and what are we going to do. And the challenges are myriad. They start with good sanitation. We need to prevent people getting infection. If it's malaria, you need impregnated bed nets, but actually for bugs, you need good sanitation, clean water, washing hands. Remember the heyday of dreadful MRSA in the noughties and how we had to have obsessional hand washing in hospitals to drop it to acceptable, very low levels? Well, we need that across the world, everywhere, not just in the healthcare setting, but also in schools, in food preparation, everywhere. We need people to understand so that they only use antibiotics when they're really used. There's quite a lot of data showing that antibiotics are prescribed routinely in this country and therefore across the world for viruses, flu, coughs and colds. But antibiotics don't work for viruses. It's a very difficult patient and public demand and expectation, and the clinician doesn't actually have a rapid diagnostic to say they're right, it's bacterial or viral. It makes it very difficult. We need prevention from the scientific perspective, vaccines. We need better diagnostics. We're going to need better drugs. And of course, we need a Susan in every country around the world. We need good surveillance. We need to know what's going on. And we don't. Because laboratories are poor, surveillance isn't there. Let alone, how are we going to fund all these innovations that are needed and then make sure they go round the world? But the challenges are even greater than that. You know, we need far more basic research and understanding. The low-hanging fruit of new drugs have been found. I've mentioned surveillance. Well, wouldn't it be nice to have real-time surveillance, really good, digital surveillance? We're going to have to look at that. And why is it that America leads the way on using antibiotics for growth promotion in animals and fish farming? I think it's disgusting. Many of you will know about the Longitude Prize. Many of you will have voted, along with 100,000 of the public, for it to be focused on a rapid diagnostic for AMR. And we're reaching, tomorrow we're going to celebrate 1 year of that prize being in existence in this country. And clearly we've got this problem of how do we, as clinicians, in practice, look after the drugs we've got and try and make sure that we use them only when they're needed and move forwards. It is very interesting how quickly you can change practice when you've got a good intervention. And this is actually in Norway, but it happens in Scotland, they've written and told me, for salmon farming and trout farming, mixing 3 vaccines together, individually vaccinating every fish, and then look at the impact, first in orange, on the use of antibiotics. Secondly, in blue, it doesn't stop good production. In fact, it helps. So, these days, I've stopped being a clinician. I used to look after sickle cell patients. I'm still pretty good at research policy and strategy, but I've had to take on the mantle of global advocate, really, because what I heard when I developed this annual report that brought this all to my attention was that the experts knew what the problems was. The experts knew what needed doing. But actually, they hadn't got a voice and they didn't know how to make it happen. And I felt this was such a grave issue that I had to give voice to it and try and get it sorted. And as my friends would say, you know, why stop at just Britain when you can go global? But think about it. This is a global problem. And we've got to raise awareness everywhere. And that includes vets and people who do animal husbandry. We've got to make sure that we talk to and fix the access issues. If you go to rural India, you can buy drugs over the counter, but are they good drugs? And will you get a whole course? Let alone, did you need them? We need that surveillance I've talked about, as well as the innovation. And governments across the world have got to sort all of this out. So we have taken action, and I should put on record my thanks to both the Prime Minister and the Chancellor for their active support. So not only commissioning the O'Neill Independent Review, but rather more. So we went first to the World Health Assembly. I published my report in 2013 with a new motion. We had had a couple of resolutions before, but no action. But you can't have action without a resolution, so we had to have a new one and work on the assumption that we could make something happen as a result, which was actually to produce a global action plan, which is One Health, so it's not just humans, it's animals, it's everyone, and get that passed by the World Health Assembly, 194 countries, this May, and it was. The Director General of the WHO, as you heard, I'm on the executive board, was probably quite canny in making me chair the Strategic and Technical Advisory Group. I'm not expert, but I'm quite good at sharing things and listening and making things happen. What do you do when someone out there is making a noise? You bring them in the tent and say, help us get it sorted. So I chair that, and we helped the WHO produce its global action plan and get it through. I also want to thank our Foreign Office. The diplomacy that has gone on and is going on is amazing. You should hear ambassadors around the world talking to the subject of AMR. They're really quite conversant. Most of them have had to read my book. I hasten to say I do not get the royalties. My colleagues who co-authored it have the royalties. And because of this unprecedented joined-up government that we showed for Ebola, but I don't think we normally show, we're doing a lot very well. So we work with the states on something called the Global Health Security Action Plan, and we, with Sweden, the Netherlands, and a number of countries, lead the AMR strand to make sure that A, it delivers, and B, it's in line with the WHO Global Action Plan. Europe has always been good. We are the best in the world on veterinary use in Europe because of the regulations that came in the early noughties. Very good. But there's no reason why you would notice it. The G7 health ministers, well, in fact, Angela Merkel made G7 in the summer debate AMR, and it was in their heads of state communique. The Turkey G20 communique, you'd have thought would be all about Paris, and they've never touched health for G20, thanks to Prime Minister Cameron, says that they will address AMR next time round, which is great because it's China, and we want them to get the finance ministers to look at novel funding mechanisms and a big fund for innovation. Jim O'Neill and I were down in Brazil talking to them about how they should help lead the solution rather than look at a resolution and gripe, come in early and shape it, and they've agreed. So in the people-to-people economic dialogue, they've now announced that they're going to help us co-sponsor a UN General Assembly high-level meeting. China, when President Xi was in town about a month ago, not only said they'd make it an issue for the G20, with Prime Minister Cameron, they announced a new R&D innovation fund. We've put 50 million in. We're just setting up the private-public partnership so that others can join in and we can start to spend the money. India, Prime Minister Modi, last week, in the final communique, said we would all work together. This would not happen without a Prime Minister absolutely committed, and it is impressive what they are getting people to talk about. And you start with awareness and talking about it, and then you move on. So we are committed to having, everyone told me it wasn't doable, but we're going to do it, a UN General Assembly meeting next September, because we think, because it's animals and as well as humans, it's across the whole system. Because antibiotics are a global common good, we have to take it right up there. I've been to New York, met the President of the UN General Assembly. We're doing everything we can with a lot of support, as I've said, from other countries. Clearly we need to work on more than awareness. We need to work on this conservation, the innovation, and Jim O'Neill's work is really leading the way on that. It is wonderful when an economist, who now, if you haven't noticed, is Lord O'Neill and a minister in the Treasury, which is terribly helpful, gets it and starts talking about it and writing op-eds in newspapers, because it takes it up the kind of general awareness level. And I do believe that when he produces his final paper, there's a few more to come. There's one on agriculture, there's one on vaccines, there's the final one will be next May on innovation, funding for innovation and everything. And he talks to the chief execs of all the major pharma and biotech and everything. We think it's doable. When we were in Brazil, we met not only their great research establishment, Fiocruz, and some of you may have joint work with them, but we actually met some very exciting people in the animal husbandry area. They are the biggest exporters of beef, pork and poultry. And they said, we've got two streams of growing all this meat. One for Europe, because you won't have it if it's had antibiotics for growth promotion, and one for America and the rest of the world. We can do it. And they are exploring all sorts of novel ways to increase the meat yield without using antibiotics. So it was a really uplifting visit, and we do believe it can be done. The Chancellor is terrifically supportive. In the budget in March, the last budget before the election, he gave us £200 million for the Fleming Fund, which is a fund to develop laboratories' capacity and capability in poor countries and their surveillance. And we're going to do quite a lot of work in partnership with the Gates Foundation and with the Pasteur Institute around the place. So already we've got that 200 committed, we've got 50 million committed to an R&D innovation fund, and the understanding that if we can get to the right place and get enough countries involved, our country will commit to a major global fund to support antibiotic and antimicrobial development. And it's important that we spread this out. It is not for us to solve this problem on our own or to fund the solution on our own. But we do need to play this leadership. And we're probably getting to a tipping point, because every time I travel, people say, yes, yes, we want to join in. We want to be part of this. We want to help. I think that everyone is helping. And as a result, we can get there. I went to the most wonderful science meeting on new antibiotic development. And a German Fraunhofer Institute is looking for antibiotics in insects. Just think of it, the insects live with all these bugs, and most of the time they're healthy, and they're finding them. And they've got a deal with Sanofi to develop them and take them through. There are novel ways, novel places to look. We need to open the box and look at all those antibiotics that were made and discarded because of side effects, or they seem to work but not quite well enough. Can we manipulate them? Now we have genomics, now we have structural chemistry and things to lose the side effects, or to make them work just that bit better. There is a better world that we can see, a better world that we can kind of feel that will save humanity. And you know, I say that, and at the beginning as I went on this, I think it's becoming a crusade actually, people said, no, you're exaggerating. But is a Boeing 767 falling out of the sky in Europe every week an exaggeration and getting worse? I do believe we owe it to the world to sort this out. And the final thing I wanted to say, but you'd heard about it, was if you want to get a movement like this, you have to take the public with you. To take the politicians with me, you know, they listen to reason, but actually they listen to the public and the media. So I thought, right, then we will play them at that game. So we did, 3 of us write the book, though it gets to be my name on the front, but not me getting the money, as I said. And I did do the TED talk, and I spent a lot of time talking about this problem. But I know that what I bring to this is the understanding of the political and governance systems in the global system, and I can make a contribution. But I want to celebrate the experts, the people like Susan and many others of you here who do the work, who look after the patients, who save the lives. I want you to have the tools you need to do that job well. And I want those tools to be available not just in the Royal Free, but in rural India. I want them to be available for humanity all around the world. So I hope you'll join us on this crusade and watch us get there. Thank you.
Sally, thank you for an inspirational talk, a problem that I think we all are aware of, and as you rightly said, many in the audience practicing doctors see it on a daily basis, and it's one of those problems that we feel, but we feel powerless in a sense as individuals to fix. So I think leading the campaign, because I think a campaign is exactly what's needed. I think you are doing a great service, not just for the patients of this hospital, as you said, and patients of this country, but something actually we feel very strongly about at the Royal Free, that we have a duty to patients all over the world, and we have a duty to lead knowledge and innovation globally. That's in our culture, it's very much in your culture, and it's absolutely inspirational to see you doing that, so thank you. Now Sally has agreed to take a few questions. We've probably got 4 or 5 minutes, so if anybody has a burning question, then raise your hand or make me aware of you, and we can ask. One question there.
Thank you very much for your great talk. I'm one of the microbiologists here.
You probably know the answers then.
We struggle with this, doctors and prescribers. Is there anything you see as clearly beneficial for us should be a carrot or a stick to improve prescribing, whether it becomes either appraisal or there's some financial penalties, or I think there's a bit of debate about what are the best methods. Do you have any thoughts on that?
So the question was, what are the best methods for influencing doctors' prescribing habits? Carrots or sticks or both?
Well, I think it'll be a mixed economy, actually. I don't think there is no magic bullet. And a rapid diagnostic has to be the best answer, rapid diagnosis, because then we would all do the right thing. Until we get that, it's quite interesting what you can do in hospitals with prescribing rules, what you can do in casualties with how you handle it. We've just done a nudge study. Public Health England set it up, and I wrote, it went over my name, to half of the top quartile of heaviest prescribing GPs and not the other half. The preliminary results suggest it's had a bit of an impact that is continuing for a few months. I think that we need to attack it with information to patients, the public and clinicians about the harm and the ineffectiveness of them, but we will have to have some sticks as well as carrots.
Professor Moore?
Even now, when drug companies discover a new drug, they'll often patent drugs with similar structures as spoilers to stop other competitors developing similar drugs. I don't know to what extent that applies to antibiotics, which tend to be more complex molecules. Have you looked at seeing whether past drugs, whether the sideline patents that were never developed could actually be developed further by new companies and reaching old patents that protected those companies?
We haven't looked yet, but if you look at when the golden era was and most of them were thrown away, their patents will be long gone, finished. Yes. So I think we're probably going to be able to rescue them if we can only find them. I mean,
but the question is, will a company develop a drug that's not protected by new patents?
Well, that's again where Jim O'Neill comes in rather interestingly. He turns around and says, you don't want to end up like the bankers, the pariahs of society because you didn't do the right thing. And what we're saying to the drug companies is, you're going to have to make antibiotics. We don't think you should lose money, but you probably won't make any money. So, we're beginning to develop a narrative which is they have a responsibility to society to help. And one of his ideas, which is where we may end up, is to have milestone payments where actually we end up from a global fund paying for the drugs, and then you can de-link volume for having paid for the drug. So there are ways we can do it.
Sally, one last question.
Thank you for your talk. Do you think the innovation in diagnosis is important as well? I'm thinking, can the public get access to nasopharyngeal aspiration? So, say like pregnancy test, you do it, and then you say, oh, it's a virus, I don't need antibiotics. Do you think this in the future could contribute to less antibiotics?
I absolutely do. We think that rapid diagnostics are a very important part of the solution, and the Longitude Prize is about having a rapid diagnostic that actually is discriminatory, that is affordable. I was going to say cheap, but it is affordable, is rapid. It can be used because in the Sahara or in here on a murky winter's afternoon, because we do think it's very important. Yep.
Sally, thank you. I'm going to give you a rest for a few minutes before we ask you to do some of the medical student prizes. But I've asked everybody to put our hands together. Right. It's now my privilege, as I said earlier, to ask Jon Rubinstein, who's a master of the Cordwainers Company, to come and say a few words. Jon. Thank you.
Then Sally, all those here today, many distinguished medics and in other walks, I can't tell you what a pleasure it is for me, for once, to take the graveyard shift, because I know that there is plenty of attention around me should I need it. And thank you. It's an enormously hard act to follow such a distinguished speaker to talk about such a topical subject. And I thought I was forearmed. Here it is in the Times this morning. Well done, you beat it. Thank you very much. So, we're here to celebrate the achievement of some wonderful people in medicine today, not just those who will walk up and take the awards that they so richly deserve, but all those people around us who've made it possible for them to gain that knowledge and experience which helps us in all our walks of life to prosper whilst being kept healthy and out of the sort of difficulties to which Dame Sally has referred. I once read on a British Rail poster, Harwich for the continent, Frinton for the incontinent. Well, I wouldn't go to Harwich, I'd come here, because just last month the nurses here walked off with the Nursing Times Awards for continence treatment. Just one example of the areas in which this wonderful institution excels nationwide. And of course we have with us today the wonderful team who put together this revolutionary Ebola treatment, a hospital here that excels worldwide. We are truly in the presence of groundbreakers, and it's humbling. I wanted to say further that for the Cordwainers who have been associated with the Royal Free Hospital since 1828, that association was nurtured. Just 4 years later was an atrocious cholera epidemic. And those medics in those days confronted the same questions which Dame Sally has drawn our attention to today. They didn't know the etiology or what caused cholera, and it wasn't another 20 years until they found out that it was linked to the water supply. But they found a solution, and that's what's important for us, that we go away today knowing that we've got the expertise, the enthusiasm, the skill, the intelligence, and the wit to beat these problems and to cut them down to size so that all humanity can benefit. Not so widely known is the fact that after our dearly beloved William Marsden left this hospital, having set it on its feet with a massive legacy in the 1850s, his son, Alexander Marsden, continued the association. A master of our company in 1898, he was the general superintendent here in the 19th century. So our association is long, deep, and dearly loved. Now, it really comes down to recognising those people who've made the achievement today. So I shall now pass over to our learned hosts and invite the prize winners to take their plaudits from the assembly. Thank you very much.
Now, unfortunately, Sally has to dash off. She has another speaking engagement at the Royal College of Obstetricians. But before she goes, I'm going to ask everybody to come up quickly for a group photograph with Master and with Sally. And just to remind you, next year's 2016 Marsden Lecture will be held 3rd Thursday of November, same place, same time. Thank you all for coming.